It's my pleasure to introduce our next speaker, who is Gary Rosenberg from neurology at the University of New Mexico. He's going to speak on biomarkers in Binswanger's disease, targeting small vessel inflammation for treatment. Gary?
I want to thank the organizers, Dr. Bossetti and Dr. Galis, one for putting this very interesting conference together, which is, I think, a critical stage, and also for inviting me. So dementia is, due to vascular cognitive impairment, is really one of the major health problems. And it's projected to increase greatly because of the confluence of increasing aging of the population and the increase in vascular risk factors. But in spite of its huge importance, we don't have any treatments for the vascular forms of dementia. And I think one of the major reasons for that is that we're not dealing with one disease. We're dealing with a heterogeneous group of diseases. And in all medicine, if you cannot define what you're treating, you're really unable to treat unless you have huge populations. So I think if we're going to get anywhere, we have to narrow this down. And the most common form of vascular cognitive impairment is the small vessel disease, and I'll try to convince you of that. And I'll also try to convince you that it's an inflammatory disease and not necessarily stroke. I'll give you some evidence for that. So how do we deal with that? Well, I've decided the only way is with biomarkers, and to have biomarkers that are more complex or complex enough to deal with the complexity of the pathological changes. But the big problem there is to verify a biomarker, you need an autopsy, which is not necessarily available in this group of patients. So we chose to collect a large number of biomarkers at the beginning of the illness and then follow patients for multiple years to try to get as close as we could to the best clinical diagnosis. And I'm going to show you that that approach at least narrows it down to multiple subgroups, some of which I think are going to be amenable to treatment, targeted treatment, fairly soon. So what I'm going to do is describe a set of validated biomarkers that identify the form of vascular cognitive impairment that's due to small vessel disease. And these biomarkers are collected as the patients come into the study. We take everybody with suspected vascular cognitive impairment. They usually have an MRI that shows the quote-unquote white matter disease, which I'll show you is really not a very good marker. And then we follow them to try to get a more accurate diagnosis. And I think the data that we're collecting and that I'm going to show you is going to show that the group that we want to target is a group that has an inflammatory process, which is disrupting the blood-brain barrier. And because of that, we have not only a marker to follow, but we also potentially have some targets for treatment. So what is this thing that we call vascular cognitive impairment? It's clearly a heterogeneous process. Large strokes, embolic strokes are going to cause it. Thrombotic strokes are going to cause it. But the major form is this small vessel disease related mainly to hypertension. And there are rare forms. You heard about CADASIL, 1 in 1,000. Hypertension is everybody. So this is the major form. And because it's been lumped all into one form, we've never been able to get a focused treatment going. And I think we fell behind. 20-some years ago, Alzheimer's group got all together. They have 38 centers. They forgot us. And so very little research was actually done on the vascular risk factors. And I think their approach is the appropriate one. So I'm going to talk about two forms of this disease, or basically one form of this disease. So you have large vessels, multiple infarcts, and lacunar strokes in the basal ganglia, or you can have small vessel disease, which leads to white matter change. And the white matter change, I'm going to use the term Binswanger's disease, and I'll try to argue that that's the best way to do that. If you deal with large vessels, you have a sporadic course. Clinical studies are going to be very difficult because you don't have a predictable progressive process. Whereas if you deal with white matter injury, you have a potential target. This is one of the only studies, there's very little epidemiology. This was a wonderful study out of Lund where they looked at vascular dementia autopsies. If they were pure vascular dementia, most of them were small vessel. If they were multiple types, and as you know, when people die, they have all sorts of pathology, small vessel was again the number one. So small vessel disease is arteriolosclerosis, hypertension, diabetes. There's progressive growth of the white matter lesions, executive dysfunction, and gait imbalance. It's a classic patient. We've now followed a bunch of these patients. And I'll show you that this is an inflammatory process. Otto Binswanger described this disease in 1892. He was born in 1852. He was a student of Alzheimer. Actually, Alzheimer named this disease Binswanger's disease. It was probably syphilitic white matter disease due to vascular disease. This is the classic picture. Unfortunately, 20% of normal individuals can have this picture when they're in their 70s and 80s. And we've done that study in a very healthy group of people. You cannot use this as a diagnosis. I get sent patients all the time saying, I have Binswanger's disease. They're perfectly normal. Some of them. The question is to weed out the ones that are not. And the ones, and we had, this is actually a very advanced brain from the Radcliffe Infirmary of a patient when they weren't treating hypertension very well. And you can see gliosis, huge gliosis. This is dead tissue. And the demyelination spares this U fiber. And that's the key to this not being a stroke. If it were a stroke, cortex, white matter would be involved. But this is the classic pattern. And what's the pathology? This is the pathology. This is the most common form of arteriolosclerosis, fibrohyalinosis, all kinds of different terms. And there's inflammation around these blood vessels. These are PG1. I had the opportunity to go over to Radcliffe and work with Margaret Asiri, who had a large number of vascular dementia patients, and we stained them all for metalloproteinases a few years ago. And here you see the macrophage, and this is MMP2 in the astrocyte, and this is the GFAP. We've recently done dual labeling now with immunofluorescence, so we know that these are astrocytes. But more interesting, we found stromiolysine, MMP3, in the macrophages. So the metalloproteinases open the blood-brain barrier and they break down myelin. So they're the perfect molecule to cause this process. So what are these metalloproteinases? These are an interesting group of 26 molecules. They were discovered for cancer actually by Lance Leota, who gave me the original type 4 collagenase to use. It's a signal peptide covering the zinc active site, and depending on what things you hang on the end, you give it different names. The simplest one is matrolysine. It's only the zinc. The one that is most studied because it can be measured is the metalloproteinase 2 and 9 gelatinases, and they attach, they have a hinge here, and they're a fibronectin binding site, so they go to the basement membrane. And then there's a transmembrane type. The neurovascular unit is the site of action of these molecules. This is a MMP2 immunostain around an astrocyte. And you can see that it's in the foot process, and it wraps around the foot process. It modulates your barrier all the time. It's not open or closed, it's modulated. And some years ago, we developed this model In a normal person, metalloproteinase bound to the astrocytic foot process is constantly being activated. The MMP2 is constantly being activated, breaking down the basal lamina, restructuring it. That's a normal process. But when you have hypoxia, you activate NF-kappa B and IL-1 beta, and you turn on the MMP9 and MMP3, which really are very toxic. And I won't go into how we work this out. We have an animal model, spontaneously hypertensive, stroke-prone rat, which develops everything that the Binswanger patient looks like, but we accelerate it. And what happens is hypertension leads to hypoxia, and we've actually measured this with electron paramagnetic resonance in the animals. HIF gets turned on, the FUR gene turns on the MMP membrane type, making the active MMP2, attacks the blood-brain barrier, causes edema, demyelination, white matter damage, and then there's a repair process. So now I want to show you how we've used this to develop biomarkers. The first biomarker that we looked at were the metalloproteinases in the spinal fluid, and we now use a thing called the MMP2 index, which is indexing the MMP in the spinal fluid to the MMP in the blood, and you need to do that to tell whether it's endogenous or exogenous. But you can see in the other name for the Binswanger's disease is subcortical ischemic vascular disease. I flip between those two depending on which audience I'm talking to. We found that this goes down, and the way that we've correlated that is with the albumin in the spinal fluid. Albumin is made by the liver. It's never in the spinal fluid except in very small amounts. And as the concentration of albumin goes up, the MMP2 index goes down. So that's one of our biomarkers. The other important one is to measure the blood-brain barrier permeability. And I think this has been the major advance that we've been able to do. The early studies, mainly by Anders Wallen and his group in Gothenburg, showed that albumin was elevated in vascular dementia patients. And then there was a series of patients with MRI, one from Japan, one from Wardlow's group in Edinburgh, and then from Marcus's group, showing the blood-brain barrier was abnormal. But these were qualitative. These were not actually measuring. And we developed in humans the dynamic contrast enhanced MRI with gadolinium. It was first done in animals by Ewing, and actually Sahid Tahiri, who's here in the audience, was a postdoc and worked this out. These are rapid T1 measurements. Every 3 minutes we take a T1 measurement for 21 minutes, and we get a PATLAC graphical plot, which people who work on the blood-brain barrier will appreciate, and we can calculate an actual K for every single pixel. We worked it out in controls first. This is a work that we published a couple years ago with Dr. Tahiri. The histograms show the permeability spread in the brain of a normal person, and we picked a number in 20 patients. And these are the normal scans, and these are scans of patients with Binswanger's disease, and you can see there's elevated the shift of the permeability curve in the VCI patients. So that was work we did at 1.5 T, and I'm going to show you some unpublished data now that we've now collected in about 30 patients with 3 T. It's really very much more interesting. This is the MRI of one of our typical Binswanger patients. I want you to note here that this is the periventricular. This is the subcortical. Periventricular changes are normal. Normal aging gives you periventricular changes. You can't use those as pathological changes. The real changes are out here in the subcortical area. And the other thing I want you to note, this is very symmetric. This is not a stroke, stroke, stroke again. And this is the permeability map from that patient. And you can see that the permeability is increased. Here is a control group, 6 controls. Some of them even have white matter disease here outlined here. And these are 6 patients. And the permeability is around the edge of the white matter lesion. So it's sort of an inflammation around the edge. These are the biomarkers we use: albumin index. We measure the spectroscopy to look for ischemic tissue. We measure the MMP2 index and the permeability. And when we get all of these together, we say the patient has the Binswanger form of the disease. And so far, in our first 61 patients, about a third have that type. A lot of them have what we call leukoariosis. We don't know exactly what that is, large vessel disease. And we've now compared that with our a score that we make with 10 different factors, including the Alzheimer factors, and we found that it does correlate well with our final diagnoses. And this is total permeability matched up to the score, and you can see in our patients the permeability is open. So we now are trying to find some outcome measures to use to test drugs. There's functional, blood-brain barrier. There's structural, diffusion tensor imaging, which is much better than just the FLAIR MRI. The FLAIR MRI is not a good measure. And then the behavioral and the time frame is different. So in conclusion, we think that biomarkers based on the pathophysiology can select a more homogeneous subpopulation of small vessel disease patients with this inflammatory form, which we'll call Binswanger's disease, for targeted therapy. And it will now be possible, I think, to find the group of biomarkers that will help us tailor or target our treatments. And the gaps, of course, are to validate this biomarker approach in a much larger population, to identify some outcome measures, and then the major thing will be to develop a group of anti-inflammatory drugs that can be tested. And as you know, these kinds of studies, if I can get this slide, oops, where'd it go? I thank NIH for funding for both our Clinical Translational Science Center and for R01 grants. The group that has been working on this is my clinical group. The early collaborators were Lance Lioto, Stetler Stevenson, John Shaw did the... So anyway, thank you very much.
Thank you very much, Gary. We have about 3.5 minutes for questions.
Hi, very nice talk. Radostan from Dharma. Did you have a chance to carry out any structural studies to see what's going on at the level of the endothelium? What's the basis of this permeability, enhanced permeability? Are the junctions open? Are there structures appearing there?
Yeah, I didn't have time. We have an animal model, and I didn't, in the 15 minutes, I couldn't put them both in. But the animal model, which we published, does have changes in the tight junctions. I don't know if that's been published yet, but there are clearly changes in the tight junctions. We're studying angiogenesis, and the animal model is a hypoxia-induced blood-brain barrier opening through MMP9 primarily in the rat. So there are structural changes in the endothelial cell, very significant.
Thank you. Please.
Howard Crystal, thank you, Gary. So that subject that had a lot of abnormality and flare that did not have Binswanger's, I assume they did not have any abnormalities in blood-brain barrier, and what cause, what are we looking at?
Well, that's, of course, that's the most important question. Well, anyway, we published the first CT scan of Binswanger's disease some years ago. And then there was an editorial in Lancet that there's an epidemic of Binswanger's disease. This was a disease I'd never heard of in medical school. So I knew they were wrong, and we had an MRI machine that we could use anytime we wanted. It was a research machine. And we had 100 normal people, age 65 and over, and I scanned 100 of them. There were 500 in the group, up to 90. 30% had white matter changes. And we found 7 that had complete white matter changes. We did spectroscopy on those 7. They were perfectly normal. They were in their 80s and 90s. Nothing. They had no ankle jerks. That was about it. So I think this is a potentially, this is a normal change. You know, just like in the lung, you see some fibrosis, you see stiffening of arteries, aging. I think people who are calling these strokes little strokes are misleading us.
Okay. David, a short question, please.
Yeah, so you showed data from this dynamic MRI technique where you had gadolinium leaking. I just was curious if you looked with diffusion tensor imaging or something of that ilk, do you actually see at the same time or earlier or later sort of a change in the white matter?
Yeah. That's what we're doing. We work at this amazing institute, the Mind Institute, connected with the university, and we have all that data. And my imaging people are telling me we're seeing changes, and I think other people have said this is it's much more accurate to look at diffusion tensor imaging. And I think once we get the diffusion tensor tractography,
Yeah.
we're going to see some amazing things, because this is basically a disconnection syndrome. And if we can understand, I mean, the brain is put together by connecting white matter to the cortex. And as people get this disease, they break down the white matter. And so we'll start seeing these patterns once we have sophisticated, and the center has all that ability, free connectivity, all that sort of stuff. But
Okay.
that's going to be another 6 months.
All right.
I'm going to have to call a halt, because to be on time for lunch in the next session, maybe the last two questions you can come up and talk to Gary.
So quick question, how is this related to multiple sclerosis? You're talking about, demyelination, inflammation, and, flare, hyperintensity.
Yeah,
multiple
multiple sclerosis. Can you handle that in 4 sentences?
Well, actually, these lesions, which are around the edge of the white matter damage, look like progressive chronic multiple sclerosis. And I used to run the MS clinic, and I would get sent people who were in their 50s, and they said they have MS, and it turned out to have vascular disease. That's how, one of the ways I got interested. So I think from a flare, it's very hard. But there are characteristic features of MS in terms of locations that are different than these patterns.
Okay, that's 4 sentences. Francesca, did you want to say something about